Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, guys, welcome to another episode of the Real Integrative Medicine Podcast. This is going to be an important discussion for you if you have pain, if you've had pain in the past and you have gone for any kind of diagnostic imaging. We're going to throw X-ray, CT, MRI, ultrasound, all of those into that camp. I am joined today by one of my longtime colleagues who's been on the podcast before, Dr. Kirstie Griffiths. Thank you so much for joining me today and for us to keep going on this conversation that we've had in the past about pain and understanding pain. But today we're going to specifically talk about diagnostic imaging. So thanks for being here.
Thank you so much for having me.
So this topic I think is so important because I always struggled as a clinician to help patients frame the importance, value, maybe sometimes lack of value of various imaging techniques. And even up until when I stopped working with patients, imaging is held as this this golden ticket to understanding your body and understanding your pain. And the more we learn about imaging and we really know that that's no longer the case, I would love for you to give us a little bit of a background for how you got to this space and being such an expert in this area, and frame up the conversation for us around why we need to think twice about how we feel about diagnostic imaging.
So that's a great starting point for our conversation today. I think as a student, this was a topic that came up when I was in school that I initially was quite interested in. I found it very fascinating, partially from a personal experience with having had these sort of tests, in the past, and also because the research showing some of the limitations and where we're using these incorrectly, it's relatively new. So there's really been a shift in the last decade around, how we're using these tools, so much so that there's actually been some changes in the province of British Columbia where they've changed people's practitioners' access to using things like X-rays as a screening tool because of the updated research that we're seeing. So between being introduced to this topic as a student and finding it very interesting, and then that was coupled with starting personal practice and having this be a question almost every day in practice that people were asking if I could send them for an X-ray. They were either asking me to refer them, or they were maybe coming to me after seeing another healthcare provider who had sent them for an X-ray and looking for answers that they weren't getting.
Yeah. And I think, as we've evolved our understanding of pain, right? Which in the past, pain, if we asked maybe even the layperson to describe pain, they would say, well, there's tissue damage, right? Like tissue damage happens and then we experience pain. And in the pain world, we've really updated that definition to say, it's actually so much more than that. It's tissue damage. It's perceived tissue damage. So even if your brain thinks that something's going wrong, we can have pain sensations, or we can get that signal for our brain to experience and feel pain. We know not all pain is, born at the site of the injury, that some pain is actually born more centrally where our brain is giving the signal that there's pain versus the actual area itself being, damaged as maybe we'd always thought. And as we've updated our, the way we think about pain medically, I don't know if our updates around the way we use imaging has come along with it, because when we do imaging, it's kind of implying that we're just looking for a structural thing. But I would love if you could kind of describe why there is this disconnect between what we see on imaging and what a patient experiences, because I'm sure we've all had that experience.
Absolutely. So, a big piece of that is actually what you just pointed to, which is that our understanding of pain mechanisms, especially in the case of persistent pain. So, in cases where people have had pain for longer than 3 to 6 months, we know that the mechanism of what's creating pain for those people is often different from if you have an acute injury, like you sprained an ankle yesterday, your ankle is swollen, it's sore. That has an entirely different process that's creating that pain signaling versus pain that has lasted or has been kind of on and off for months or years at a time. So that's actually my area of interest stemmed from research that I was part of when I was a university student. The clinician that I was working with was studying pain mechanisms and looking at two different groups of people. So we had people who were considered healthy, normal, not diagnosed with any particular condition. And then we were looking at a group of people who had been diagnosed with a form of chronic pain, fibromyalgia, rheumatoid arthritis. There were a lot of different diagnoses that could fit into that category. And then what we did was we exposed those two groups of people to a pain stimulus. So it was a capsaicin cream that we put on their skin, makes it feel almost like a sunburn in that area. And then we measured their brain activity. And at the same time, we asked them to rate their pain. The challenge with pain in medicine is that we don't have great ways of measuring this. One of the best tools that we have is what's called a visual analog scale, which is asking someone to rate their pain on a scale of 0 to 10. And that is challenging for patients because they realize how subjective that is. Like, you could pick whatever number you want. But the thing that's very interesting was that when we looked at what was happening with the brain activity and we, cross-referenced that with what are people saying about their pain, what we learned is that the people who didn't have chronic pain, they rated their pain levels lower and their brains were responding differently. So when we look at the level of activity happening in their brains, it was entirely different from the group of people who, with the exact same stimulus, said that hurts more, and their brain was also responding in a different way. So that had nothing to do with the site of where the pain was applied, which was on their arm. That activity was being measured in their central nervous system. And this is the challenge with if someone has back pain and we're taking an X-ray or an MRI or a CT of their back, we're assuming that there is structural tissue damage when oftentimes that pain exists in the absence of anything wrong with the muscles, the joints, the nerves. Everything can look perfectly normal because the pain that people are experiencing is actually a function of what's going on with their brains.
Yeah, and I'm sure for our listeners, like, I want to go through both scenarios here, but there is that scenario where you have something like a feeling in your body that something's wrong with you. And this could be with lab work too, truthfully, like whether it's lab work or whether it's imaging, where you know that something is quote unquote wrong inside your body. And then when we apply the best available, I'm saying in air quotes, testing techniques. And for physical pain, we often use imaging. And then for other things, we use things like lab work. And the result comes back and it says, there's nothing there.
Yes.
How discouraging that is for the person, because it almost makes them feel like medicine is saying it's all in your head. It almost makes them feel crazy. Like maybe they're like, maybe I am imagining it, right? Maybe there is nothing wrong. But that feeling of like having a concern and then looking for validation with a scan and then having that scan come back and say, well, there's nothing there. Like that's just got to be the most disheartening feeling as a patient.
For sure. And we see it all the time. And to make that situation more challenging, we couple that with, if you're living in Ontario, which I imagine a lot of people listening to this, maybe are practitioners in this province, it's also really hard sometimes to get access to these tests. So now we have this lag where people are sometimes waiting 12, 14, 16 months to get an MRI or a CT. And they're hanging their hat on that information alone to be able to give them the answers that they've been searching for. And to make matters worse, there's often a lack of intervention from now until the time that they have the testing done, when that's actually the window of time when it might have been the most useful to use the tools that we already know are helpful. We already know that in the vast majority of cases, conservative care that includes manual therapy, exercise, lifestyle changes, stress management, all of these are actually the gold standard for how we manage this type of pain. But those things become inaccessible, or things that people are afraid of doing because they feel like they need to wait until they have the certainty that's coming from that testing to then get an answer that says, well, this looks perfectly normal. And without the context of the person who's explaining that to them saying, this physically looks perfectly normal, but it is not to say that you are making the pain up or that it isn't real. It's just telling us that the mechanism of your pain is something entirely different. That's the piece that I feel like is missing for a lot of people. And it's such a frustrating situation for people when that's usually the end of the conversation with their healthcare provider. Okay, everything looks good. Best of luck, right?
Yeah, best of luck. And it's so interesting because the longer that patients experience their pain, the more of that, like, we'll call it neural wiring, that happens to reinforce that this area is painful. And I definitely, this is something I had to come to learn and understand. Like, I studied chronic pain and central sensitization often in, cases like endometriosis and whatnot, where I felt like I had really great understanding of how, if we left pain untreated for a long time, that the brain's adaptation to that was going to make it harder for that patient to get ahead of in the future. So as you're waiting for that test result and you continue to live in chronic pain without doing anything for it, we're actually making it more difficult for you to undo it later.
Mm-hmm.
But we're
Exactly.
waiting for the image as if it's going to change something. And I think that's such a missed opportunity, just like you just said.
Yeah. Yeah, and there's, that side of the coin, which is everything looks normal, you must be fine. And then there's the whole other side of the conversation, which is you can have findings that look really severe, and that doesn't necessarily correlate well with people's symptoms or prognosis. And so on the other side of that, I see patients who come in and they say, oh, I went for an X-ray and I have very severe degenerative disc disease. I have, and they'll know the levels and the segments where there's this arthritic change. That might not even have anything to do with where that person is feeling pain. And so then we get into this whole other phenomenon called pain labeling, where we start to identify with something that we're viewing as a structural change that's a permanent sort of damage. And that then actually makes it more difficult for people to recover because they're associating their pain with something that can't be fixed or changed.
Yeah, it's interesting. And I want to share some of my personal experience with this because I've actually lived on both sides of the spectrum. And I would say if I didn't have the coaching support that I have in the gym and all of those pieces, I may have taken a less positive path. But I had chronic knee pain I was a competitive curler when I was growing up. And it's interesting because that just got labeled as like, well, that just hurts your knees. And I lived with this chronic knee pain for such a long time. And I finally went for an MRI on my knee because no one could figure it out. And the image that came back said that I had a 2 centimeter by 2 centimeter square tear in my quad tendon. And the report was like, it's 2 by 2. It's this like black hole essentially in my quad tendon. And the report is like, deep, like severe quad tendon tear.
Mm-hmm.
So I get this report while I'm at the gym, right? So I get the like, oh, log in, your MRI report is ready. And I'm like between sets of squats. And I read this report that says I have a 2 by 2 square that's been essentially ripped out of my quad tendon. And as I was sitting there, I was like, is this the last supper? Like, is this the last time I'm going to squat ever? Like, I'm sitting here. I have my follow-up now with my doctor scheduled. I have this MRI report in front of me, and it basically says I shouldn't be walking, let alone squatting. But I was squatting when I got the results. And it's so interesting because I was grateful that I, knew enough to be like, all right, well, if I'm squatting now, I'm sure that this doesn't mean that I can't squat ever again. But there was like the results of the image itself were basically that it was going to be surgery or bust. I was going to need this like full length cast, which of course I'm Googling in between my next set of squats to try and figure out what the consequence of this tear is. And it turns out it wasn't a tear. Like the punchline of the story is it was not a tear. It was like an artifact from calcification. It was a big black hole in my MRI that only with my doctor and my trainer and like everyone together was like, well, that's not possible, Jordan, that you have a tear given what you're capable of. We figured out the treatment. We figured it out. And I'm now like completely pain-free, which is a very nice, happy ending. But put another person or another scenario in that, here's your MRI, oh, PS, you'll never squat again. That story could have ended really differently if I didn't have the knowledge and the support that I have. And I'm sure you see scenarios like that all the time.
100%. And I think it's a more common thing even amongst practitioners. I actually have a similar situation and had that exact same thought as someone who was going through this personally to say, I actually understand how this works. And in my scenario, I had gone for an MRI. Something was found incidentally. It wasn't even what we were looking at. And, it was, okay, we're going to set up a referral to a specialist. And at the time, I remember saying to my husband after I got that result back, oh my gosh, I can't believe this is happening with my body. It's no wonder I'm feeling the way I'm feeling. And then for about 2 weeks, that's all I could focus on. Like it felt like the symptoms I was having were more severe, more noticeable, more persistent. And even with the knowledge of saying, I know what's happening right now. This is called pain amplification, and it happens because this has been put on my radar. And even knowing that, I still felt those symptoms. And then fast forward a couple of months, I have the appointment set up with the specialist, and we end up having a conversation. And she says, these numbers don't make a lot of sense to me. I'm wondering if it actually might be a typo. The radiologist might have made an error. And we go back to the radiologist and it was a mistake. So what's actually 6 millimeters was written on that report as 6 centimeters. So clinically,
Big difference.
I was
Big
right.
Difference.
I was discharged from the specialist. They're like, you're fine. Everything's fine. And what do you know? My symptoms magically went away. And, I had that exact same thought of, wow, I understand how this went wrong. I was kind of advocating actually in that conversation to say, is there any possibility this might be incorrect? Because this feels like it doesn't fit. But those cases are going under the radar a lot of the time. And, it's not the fault of any one practitioner. I just want to make that really clear. My stance on this, I am not faulting anyone in the medical system. These tools absolutely have a time and place where they're very valuable, where they provide life-changing medicine for people. The tricky part, though, is that we know from the research that they're incorrectly used over 50% of the time. So we're over relying on these tools, where in the case of musculoskeletal health, when it comes to things like back pain and knee pain and anything that usually involves, tissues like muscles and joints and nerves, the majority of what you need to know as a clinician can be figured out with a good history and a physical exam. Orthopedic testing, neuro testing, and range of motion will usually tell you most of what you need to know. And then the imaging should be used as a confirmation, or if there's a question mark, it can help to rule something in or out. And typically, you use that tool when it could change the course of the treatment for someone. So in the case of back pain, let's say someone has neurological symptoms that are progressing over the course of a couple of months. That would be a time where that imaging becomes useful, because it might change the outcome for that person. That might be the time where exercise and manual therapy like physio or chiropractic is no longer the useful thing. That person might now be a surgical candidate. But in the vast majority of cases where it doesn't change what we would otherwise be doing for the treatment, it's not necessarily adding any value to have that test done.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us. Yeah. And you need I would say you need a practitioner who's able to say those things, but then as patients, we also need to be ready to hear them. Right. And I think I even, my second personal story on this is that I had a bad, like a shoulder, we're going to say injury, because to this day, I feel like, magical fairy dust got sprinkled on it and it went away. But there was a long window of time where I had pretty significant shoulder pain, and I do a sport that requires shoulder to overhead range of motion. And I did not have it for 9 months with really significant nerve pain. And the entire time through the process, while I was trying things, exercising, trying manual therapy, we tried some injection therapy into the muscles around my shoulder. We got to a point where we were it must be a labral tear, Jordan, right? It must be. We've got to this point where you've done all the things, we've tried all the things. And so I have ultrasound, I get scheduled for MRI, and there's nothing. There's nothing there. And it was so infuriating because I was brains and bodies are so stupid. There is nothing there. I got to the point where I was there must be colossal physical damage in here, because even though I know better, right? Even though I'm so very much aware that my brain had decided that my shoulder was sore, even though there was nothing we could see on any imaging. And while I waited for that next step, which was MRI, I, continued to train. I did all the stupid accessory things that I did not want to do. And then it felt like magically I woke up and my shoulder was better. But my willingness to accept that as the possibility had to be part of the solution, right? Because if I was insistent that there was something there, if I was insistent that I wasn't going to train until I got my MRI, I would have done nothing for months and months and months, probably an entire year. But it took a lot, because even as the patient, I kept having to say, my brain is making this painful. It is not, there is nothing actually wrong. But that takes a certain level of self-awareness to even be able to do that on a regular basis.
It totally does. And having, people on your team who can help you navigate the very normal fears and frustrations that come with that. It's a big part of, what I'm doing with patients is, yeah, we're providing symptom relief, but I'm also helping people figure out how do I know if movement I'm doing is harmful or if it hurts, but it doesn't necessarily mean that something is wrong. And that part's really hard for people. And rather than us playing with that edge and figuring out what that sweet spot is, it is easier, and a lot of people will gravitate toward, I'm just not going to do anything because it hurts to do it, right? And that does become tricky because, like with your shoulder, those exercises and some of those lifestyle pieces, they're often the thing that will eventually help to heal this. But it is working through, okay, just because my body is telling me it hurts, it doesn't necessarily mean that I am doing something dangerous or that it's causing physical damage. The brain starts to act like a smoke detector that has a battery that hasn't been fully charged. When we're experiencing chronic pain, we get these false alarms that are not necessarily telling us that we need to stop what we're doing. But it is, helpful to be working with someone who can who can assist in the figuring that piece out, because it can be very confusing to try and navigate on your own.
Yeah, it's funny. With my shoulder, it only hurt once I got, like, I could jerk, but it only hurt once I got above a certain number of kilos, which tells you something right there that, like, I'm so sure that, like, at 58 kilos, suddenly there was this like particular pressure being placed on my shoulder, whereas at 57 kilos, it was fine, right? Like there was obviously a fear component to my pain. And it was only the two strategies that we employed. Was one, I signed up for a competition, even though I knew I wasn't going to perform my best, but I used it as a way to mentally try and overcome the fear. But we also did what we affectionately call mind or sorry, plate loading mind fuckery, which is where I didn't know what was on the bar because it
Oh,
actually allowed me to just move based on how it felt versus like thinking, okay, oh my God, this is the first time I'm going to try and do this weight. And then my brain would get all involved. So we would like blindly load weights so that I didn't actually connect my emotions to what was happening and my fear, because that was literally creating a lot lot of the pain.
that is so interesting. That's a
Plate
very
loading
good
mind fuckery.
strategy. Yeah. Yeah, along those same lines, one of the things that I'll also tell people is when we're in that initial phase of trying to manage pain, um, it's a fine line, because sometimes the way that you approach that, where you work through the pain, is helpful. Other times, sometimes if people are in a really heightened pain state, if we keep doing something that aggravates and triggers that pain cycle, sometimes it's hard to get out of that. So my first, take with this is, let's see if we can have you keep doing what you're doing, but just add things in that will provide relief. But when that doesn't work, sometimes a short, I use the word short, period of time where we take out something that might be aggravating. Usually I trial this with people for 2 to 4 weeks. So if it's like, okay, every time I lift that amount of weight, that's when it hurts. Sometimes I'll say, lift just under that weight for the next several weeks, plus do these other things that will help to kind of dampen pain signaling. And then in 2 weeks, we try that again and we see how that feels. And sometimes just giving it a chance to not be constantly going through that cycle can be helpful. Um, but then I'll also tell people that is part of that experimentation where you're going to be figuring out where's that tipping point. And part of the process is that sometimes we actually have to cross the line and it will be painful. And to not be afraid of that, to say, okay, I know that's going to happen. And all that's doing is giving me information about where that point is right now. Knowing that when it does get irritated, it will likely be short lived, maybe for, a day or so, it might feel more sore and then it'll come back down to where it was before. But it's a good idea actually to keep testing where that line is, because it will move. As you do things that help bring pain sensitivity down, your tolerance will become higher. And if we're always working under our tolerance because we're afraid of what would happen if we do something that makes it hurt, sometimes we don't even realize what we're capable of doing. And it's a perfect example with what you described, that as soon as you didn't know what weight was on the bar, it wasn't so much of a problem to lift it, right?
Mm-hmm. It's fascinating. I really love this discussion around like understanding what the edge is. And when I worked with patients, I often would describe it as like they were living inside like a bit of an electric fence, and but we weren't quite sure where the edge was, and we would try and push on it, and eventually we'd accidentally go through it, and then we'd be sore, or whatever your symptoms would return, and we would learn, okay, well, this is like the boundary as of right now. But to your point around like capacity building and resiliency building, and even like building like a psychological capacity for the work, only happens when we like brush up against it some of the time, right? If we
Mhm.
only stay right in the center of the yard and we never go anywhere near our full potential or capability, we don't actually build the resiliency required to get any better physically and mentally. I find that so fascinating, because even when we think about like the mental health benefits of exercise, the stress reducing benefits of exercise, the resiliency benefits of exercise. It's all kind of happening at that edge of discomfort, not in the
Yes.
center where everything is like sunshine and roses all the time.
Absolutely. And yeah, that's a perfect example of how discomfort and even to some degree pain, they are actually a natural and normal part of the human experience. It becomes dysfunctional in the case of chronic pain, but our goal is to never experience pain again. That's not realistic. Like especially if you have a condition like fibromyalgia, like endometriosis, it is very likely that you are going to have flares sometimes. And so when I'm working with people, we're trying to move away from the goal being get rid of pain and never have it again. First of all, it's just not a realistic expectation for a lot of people to have. It doesn't matter if you have chronic pain or not. But instead, moving toward what would it feel like for your quality of life to feel like, number one, you understand where your pain is coming from. Number two, you feel like you have a good sense of control over your pain. So when you do have a flare, I know what I can reach for or what I can do that will feel good for this. And I also know what I might need to try and avoid doing or take a bit of a step back from because it tends to trigger the pain or make it feel worse. Just having that sense of understanding and feeling like you have a sense of control over it instead of being totally blindsided by the condition that you're living with, that is a very different way of experiencing it.
Yeah, and so much more hopeful, right? Like all we
Mhm.
really want is autonomy in our health. And it's to come back to what you said at the beginning, like the current state and use of diagnostic imaging creates a few things. One, it puts the responsibility, or the not the responsibility, but it puts it like outside of the patient, right? It puts it
Mhm.
like over here, that the answer's over here, and we're going to wait and see what the image says in order for us to move forward. And that really takes away, if we use that uh, you know, diagnose through imaging and then we'll tell you what to do order,
Mhm.
it takes away the control from the patient, especially if they're having to wait. And my latest MRI story was that it took 9-10 months for me to get a phone call for my appointment, not just for me to get the appointment, but it took 10 months for me to get a phone call about my appointment. So if you're waiting, if you're using that as the wait time, you're putting the control outside of yourself, but we've given control to a thing that is actually shouldn't ever own the control, or be the decider, because you can move, you can make change, you can, implement strategies regardless of what this thing actually says.
Mhm.
Um, but in doing so, like the current pattern in which we use imaging, there is a lot of waiting. There's a lot of like, well, let's see what it says. But it doesn't really matter what it says, because what we want to work with is what you are capable of. And your MRI doesn't say, oh, she should just do squats to a box for 3 months, right? Like that's not what it says. It's saying something that is unrelated to how we actually should carry out your plan.
Completely. It has to be taken within the context of the actual person and the individual case that you're working with, because everyone is different, and how that person's imaging findings actually correlate with their symptoms can vary so much that it's a mistake to rely 100% on what you're reading on a radiology report.
Hmm. Hmm. So for our people who are currently waiting for their phone call to get their imaging, like how do we pattern interrupt this? Because I think that it probably comes from us empowering the patients. I think the clinicians are trying, truthfully. Like
Mhm.
I've definitely, even in my own experience, we didn't do imaging right away. We were waiting or we did some in-house ultrasound, which is fine. But then, the more heavy hitting style of imaging was put further down the line because it wasn't going to help us in the moment. I do think practitioners are changing. I will say it is hard as a practitioner to change the order in which you order things when
Mhm.
patients come in asking for it. It's because it makes your patient feel like you don't care if you don't order the thing that they're looking for.
100%. I think that's actually a big piece of, I think, the education for us as practitioners is understanding how to navigate that conversation with your patient without them feeling dismissed. Because it's a very different thing to have someone leave your office feeling like you didn't order the imaging because you didn't feel like doing it versus there's a clinical reason why it's actually not in your best interest for us to do this. And one of the reasons that I give for that is I'll explain to people that sometimes we see things on there that you might start to associate with your pain that can then make your pain feel worse or that makes it harder for you to recover. And I'll tell them, if things change and we see this, this, or this, that would be a time when imaging would be appropriate because that changes what we would be doing with the treatment plan. Oftentimes, if you just provide the rationale, it's the why I think that's missing for people. If you explain the reasoning why, and for those who are really feel strongly about imaging, I will actually say to them, if it's really important to you that you feel from a mental standpoint and an emotional standpoint that you need this information to be able to move forward, I I am on board with that and I support you in that. I just want you to have all of the pieces of information of how the results of this could impact your recovery one way or the other. Give them the information, and oftentimes they'll kind of see where you're coming from. And in the times where they still feel really strongly that they want the imaging, at least you can feel confident that you've done your job of explaining why that context matters.
Mm-hmm. Mm-hmm. Um, yeah, it's like it always makes me think of like how many people have like, oh, I have a bone spur. I have a bone spur. And I'm like, I don't know if your bone spur is causing like all your problems.
No, no.
It's like my least favorite incidental finding is a bone spur. Um, but it's interesting as you were saying that, it made me think of like just there are full body MRI clinics springing up everywhere, right? And I'm
Hmm.
makes me so curious when we take some of those diagnostic tests and we put them direct to consumer, how this will play out, right? And if in 10 years we're going to be like, shit, we should not have let all those people have a full body MRI with no reason or no context, because now everybody's bone spurs is making them quit their gym memberships.
Yes. Yes, 100%. I've actually just I didn't realize we had in this province access to, there's these clinics where you can pay, and it's a private clinic, but you can get access, it's thousands of dollars, but you can get fast access to full body
Mm-hmm.
scans like that. And I do think we're walking a fine line there because there is preventative medicine and there are things that are helpful, with biohacking and getting information that can help guide our health moving forward. But then there is that other side of this conversation that we're having today, where sometimes the information can be misleading and it can actually lead us kind of down the wrong path.
Totally. Yeah, I'm so curious about it, right? Like if a 4 centimeter squared thing on my MRI could have been an incorrect and incidental finding, and we're going to find these like micromillimeter changes in people's bodies that may be normal, that may be inconsequential, they may be benign, they may not turn into anything ever, but now we start to associate them with pathology or worry or future diagnostic testing, biopsies, all of these things. Yeah, very curious about how that's going to change things as we get more direct to consumer imaging. I never want to gatekeep, right? But I also want patients. I don't know if, just because you have $1,500 to do the MRI, which I only looked up because I was at the MRI clinic. If you have $1,500 to do the MRI, do you have the capability and understanding and the support to do what you need to do with the MRI when you get it back?
Yeah, I think it should definitely be
Needs to come with
uh,
like mandatory counseling.
exactly. I was just going to say, like, there should be some parameters around who's delivering that information, and then, what is the consequence of that? Because the number of times I've seen patients who they're just sent their report, for the average person to be reading what's written on there, and sometimes it can sound awful, like I have a terrible scoliosis and I have, again, these degenerative changes. It sounds like your body's falling apart. In reality, we know that the vast majority of people over the age of 50, those are totally normal findings. Some people have no pain at all. They feel fantastic. They're healthy. They're active. And it's just a complete coincidence that those things are showing up on their imaging. So yeah, I think it's sometimes more information is not necessarily better. It has to be taken with a grain of salt.
It's funny. I always think about, I've had more than one patient in my life be like, and I got my x-ray back and it's unremarkable. Because like in layman's, like remarkable is what we like, oh my God, like this is a remarkable x-ray, right? Like we would see it as a positive thing for it to be remarkable versus like unremarkable means like there were no remarks because there was nothing to say about it. Exactly. So even that alone, right? Like we can even make and misinterpret the positive things that come back from an image without context and without awareness on what that report is intended to do. So I love this conversation, Kirstie, because I think it's, for me, I always want people to just exercise, right? Like exercise more. There is never a reason why we should be exercising less. And this discussion around pain, which, I've had before, but, also imaging, which, I'm sure they're like most middle-aged people are in line for or thinking about having imaging done on some painful part of their body. Mm-hmm. And those things lead to less movement, right? They lead to less confidence in movement, which is only going to worsen that person's physical capabilities going forward. So I think that this conversation is so important, and hopefully, people can leave this episode thinking that they also have stupid shoulders that are sore for not really a great reason, but don't use that as a reason to limit movement. Use it as a reason to get curious about why the pain is there and work towards like functional strength. What do you want to share? What are your final thoughts that you want to leave our audience with, and how can our audience find you and follow you and work with you?
So I guess my closing thoughts on this are that if we are only looking at imaging as a way to explain pain, we are really diminishing people's experience with pain and what causes it in the first place. And yes, we can use imaging as a tool in conjunction with other things. But if you want to understand where your pain is coming from, you're actually going to get a lot more answers when you start to ask yourself questions about what you're doing in your day-to-day life. That looks at things like exercise, and it looks at things like your relationships with people and your mental health and the quality of your sleep and what you're putting into your body. That will give you much more useful information, and making changes to those other areas and those other pillars of your health where they could use some support. You could do nothing at all, even like get rid of any of the back pain specific rehab. If you like going for a walk and that brings you joy and it makes you feel good and it's a way to move your body, that's going to probably be more successful than a lot of the other things that would be coming from an X-ray or an MRI in terms of the outcome of your pain. Jordan, I just want to say thank you for having me today. And for those of you, if you're interested in learning more about this, I talk at length about chronic pain, about this connection between mind and body and how that actually relates to pain management. You can follow me on Instagram. It's Dr. Kirstie Griffiths. And for those of you who are interested in, learning a little bit more about this mind-body connection, I do have a 20-minute yoga for back pain sequence from the specialized program that I offer online. It's a sequence of yoga poses that's really helpful for back pain, but taught from that clinical lens of really helping people understand kind of where their pain is coming from in the first place.
Amazing. And we'll put links to all of that in the show notes. You can click over to Kirstie's profile, but also checking out all of her other work. Thank you so much for being on the podcast for a second time. And if you enjoyed this conversation and haven't listened to the first, highly recommend listening to the first, because we do go through talking about the origins of pain and central pain versus tissue damage pain. I would love for you to go back and listen to that episode as well. This was a great through line around imaging. So thanks so much for being here with us today.
Thanks for having me.
That's it for today's episode of the Real Integrative Medicine Podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine Podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.